we're starting.
Ladies and gentlemen, our program is about to begin.
In a suspicious position.
All right, good morning, everybody. If we could just get started again, if I could ask you to take your seats. All right, so thank you for joining us in a session right after the break. So I'm Debbie Condrey. I'm the Chief Information Officer with the Sequoia project, and I have the distinct pleasure of talking about with the panel today our PULSE project, which is the Patient Unified Lookup System for Emergencies. That is usually and most always kicked into place when an emergency is declared at the jurisdictional level and then the locality level and state level. Just a little bit about myself. So I have been with Sequoia for about 7 months now. I'm actually 32 years retired from the state of Virginia as the Chief Information Officer for the Department of Health. So my background is, so this is my retirement job, which I'm loving. So I get to work on some of the things I was working on at a state level, at the national level, which is very, very exciting for me. And my background is pretty much public health and very much a passion and a heart for public service and programs that we can implement for the citizens in the country and in the states that impact their lives and provide benefits and outcomes, better health outcomes to them especially during times of an emergency, which we're going to talk about a little bit today. So I want to talk to you a little bit to kick things off about what PULSE is, and then I'm going to introduce the panel, and we're going to have some slides from them, and then we'll do some question and answers with you all. So I hope you get ready with your questions. So a little bit about the PULSE program, again, the Patient Unified Lookup System for Emergencies. It's a nationwide health IT disaster response program or platform. So we like to look at this system program as a program and not just an application or a tool. And I think you'll learn more about that as we go along, that this really is an application tool program system that provides benefits to those who are displaced during a declared emergency. And again, this could be deployed at the city, county, or state level, and it authenticates the healthcare volunteer provider. It does provide some credentialing for volunteer providers to search and view medical histories to provide better care to displaced patients. There are federated queries and patient document requests all connected to HIOs and others. The PULSE development contract was first initiated around March of 2016 with a contract with Audacious Inquiry, who was here with us today. And PULSE was implemented and used extensively during the wildfires in California in 2018 and activated again during the wildfires in the summer of this year in California. There are several states who are currently in the process of implementing PULSE, and I want to talk about those a little bit at the end of our presentation and give you some updates on where they are with their implementation. Sequoia's role in PULSE is a partner with Audacious Inquiry and the Office of the National Coordinator. So Sequoia is responsible for facilitating an advisory council, which is a group of people who volunteer their time to come together, mostly from states. There are ONC folks, there's AI team members on the staff as well. And this group of folks meets once per month to discuss the PULSE program, how it's being implemented, learn some best practices from other states, especially California, that's had some practical experience, unfortunately, with using PULSE, and just then determine how a state may, or jurisdiction, locality may implement PULSE within their own environment. We'll emphasize that PULSE is a program that's provided to states, and states are very much autonomous in the way they can choose to implement the tools and the program. There, for instance, one of the states that I'll talk about later, opted to change the name just because of some challenges with the name within their own state. So there are a lot of opportunities for some customizations for the program for the states. And as I mentioned, today's panel is going to discuss with you all and give you more information about the program itself, about the tool itself, and some of the future enhancements, the ways you can engage with us if you're interested in Pulse in your state, and the resources that are available. So I really can't see up close or far away, so I have to have paperwork. It's really pretty tough when you get older. So I do want to call out and recognize the Pulse Advisory Council members who are listed on this slide. And if you are in the room, don't necessarily have to stand up, but I do want to thank you for all of the time and energy you've spent with this program and how you have brought me up to speed in terms of what's happening in your states and what your needs are. And as we facilitate through this process, this group has been particularly helpful in determining what's next for Pulse, what are the additional functionalities that might be needed, and how things are working, and what types of educational materials or FAQs or that sort of thing might be needed. And so this group has been really great pulling all of that together. Yes, let's give them a hand. All right, so right now I want to do quick introductions of Rachel Abbey, who is a public health analyst from the Health and Human Sources Office of the National Coordinator. Rachel is, again, a public health analyst. She's currently with the Office of ONC's Office of Policy and supports ONC's public health, emergency preparedness, and EMS and health information exchange activities. And then there's Scott Afzal, who is the president of Audacious Inquiry, and Scott is also a senior advisor for CRISP, the Health Information Exchange for Maryland, D.C., and West Virginia. So thank you both for being here today. So I'm going to turn over to Rachel, and Rachel's going to speak with you all a little bit about the ONC's role and all of the Pulse implementation that's happening there. Thank you.
Can you hear me? Yeah? Okay, great. Thanks, Debbie. Really appreciate it. And thank you to Sequoia for pulling this panel together. I think it's really important to talk about Pulse and kind of bring it to the forefront as you all have been doing over the last few years. I thought it might be good to start with talking about kind of putting it into some context, really giving you all a personal story behind the reasons why Pulse is so important. Dawn from Sequoia also reminded me when we were pulling our panel together how important it is to remember the people behind the data. I mean, as Marianne said, we're all data geeks, and so, but I think it's also really important to begin to think about the people behind the data. So I wanted to introduce you to my friend Kay here, who's a public health nurse. Now, this is really not her picture because I think if I used her picture, she would kill me on a national forum. So this is just a mock picture, but I think that pictures under this circumstance really help frame the story behind Pulse. So Kay is a public health nurse with a local county health department, and she's part of an emergency response team. And so one Sunday, early morning, right after midnight, in a hot summer day, she was notified that the public health department was standing up a shelter for a community in the path of a local dam break. And so a few days before, the county had received over 30 inches of rain. And this was the remnants of a hurricane that was moving slowly up the coast. And so first responders, that's fire, EMS, police, and even public health were going door to door in several of the communities that were in the path of the dam breach. And so notifying them, the residents, that they needed to evacuate immediately. They were told to go stay with family and friends outside the area, or to, they could also go to this local shelter. Now, Kay has worked with several of these communities that are in the path of the dam breach. And one of the affected communities she noted was Ethiopian, and she knew that it was going to be super hard at this time of night to find a Amharic translator. And so, and she also noted that many of the residents were also recent immigrants. They're low income, and many were were older adults. And so, upon arriving at the shelter, which was at a local high school, Kay and a couple of her other public health nurses set up a triage center to assist the incoming residents. So the residents began coming in waves. In the first wave, Kay went up to one of the residents who was an older woman, probably about 80, she guessed, and had trouble walking. She spoke a little bit of English, was very distressed and confused. She was able to sit her down and talk with her, and she figured out that, the woman was woken up immediately in the middle of the night. She was told to get out of her house, and so she left and went to the shelter, but did not come with any of her medication. So now Kay was able to get this woman's name and some other really basic information. She figured out that the woman has some sort of heart condition, although she wasn't able to understand what type of condition and what type of medication or the amount of medication she was taking. So this was a difficulty. The woman arrived at the shelter without any family, or and then the neighbors that also came knew her but didn't know a lot about her health conditions and things like that, so that they couldn't provide this information. So this situation that I just described is, like many of those scenarios and stories, is what makes Pulse incredibly valuable for first responders. When ONC and HHS's Office of the Assistant Secretary for Preparedness and Response worked together back in 2014 with Audacious Inquiry to help create the technical framework, we really saw that it was really based upon those lessons learned. We really looked at incidences such as Hurricane Katrina and Hurricane Sandy and took those lessons to really begin building Pulse. And it was just with minimal seed money. We really had a few $1,000s from HHS's Idea Lab that really brought that together. We were super lucky to even get that amount of money, actually. So we also made sure to hear from first responders such as Kay to understand the workflow and the complexities of the types of patients that they would need to serve during a disaster. And it wasn't until 2015 when California really decided to be the guinea pig and implement Pulse and begin building it and piloting Pulse that we began to learn some additional things moving forward that we were able to build into Pulse. And then in 2018, Sequoia, thank goodness, partnered with Pulse. And they were able to really bring it to a national stage. Before it was very siloed in California, and now, thanks to Sequoia, it's really been brought to a national stage, and a lot more people are beginning to hear about it. As Debbie said, in 2018 and 2019, California was able to use Pulse in the real world to help disaster victims from the wildfires. There are teams of first responders, healthcare volunteers that use Pulse to access patients' information arriving at shelters. And in 2018, actually, disaster volunteers searched for over 200 patients in Pulse and were able to view vital information to help have an impact on their care. So Pulse continues to be improved as we learn additional lessons learned moving forward. So this slide basically summarizes, how Pulse works. Basically, it allows authorized disaster healthcare volunteers and first responders to view disaster victims' health information. We know Pulse works in California. We've seen it work. But now we really want to make it nationwide. So over the next year, ONC is working with Audacious Inquiry, Sequoia, our state and federal partners, to create a version of Pulse, which we are calling Pulse 2.0, which will allow other states and communities to easily connect and use Pulse specific to disasters in their community. And Scott's going to talk more about that next. So I do want to close the loop on Kay's story. I did want to share that the older woman made it through fine. The dam did not breach, and after about 2 days, everyone was able to return home. However, as it relates to the older woman, Kay had to wait until the county interpreter arrived, where she was able to find out the name and address of the woman's provider. Kay then had to contact the provider, and they faxed her over the medical records to the shelter. This whole process ended up taking about 6 to 7 hours, and this is only one of the hundreds of cases that she saw over that period of time. They were lucky that the heart condition the woman had was not life-threatening and that she was okay without her medication for a few hours. However, we can't assume that this is the case every time. As this story shows, the need for access to health information during disasters is crucial. We all know, there's widespread adoption of EHRs, so the data's there. Healthcare volunteers, unfortunately, may not have access to these EHR systems. Many are retired professionals or work elsewhere in other situations and just keep up their credentials. During disasters, patients seek care outside their normal environment. We know that. I remember one story Leslie told me about California during the wildfires, where they had a gentleman who arrived at the shelter, and he said, I've lost everything. My house is burnt down, my CVS is gone, my hospital's gone, and my doctor's office is gone. I have nothing. So essentially, his healthcare safety net is gone. And lastly, we can't depend upon patients' knowledge. Many are stressed and confused when they arrive and barely remember their own name. In Kay's story, we remember the woman arrived very confused and provided very limited information. This is why first responders, such as Kay and her team, and many of the disaster healthcare volunteers we all depend upon, need a system such as Pulse. So with that, I'm going to hand over to Scott, who's going to take it next.
Thanks, Rachel.
Yeah.
So I wanted to offer a little deeper history on Pulse. And Rachel's being a little bit modest. She's been involved since day one, and it goes back to this question that ONC posed, which was, in 2014, as all of these investments are going into interoperability and health information exchange organizations around the country, how can we leverage those investments to improve response during disaster scenarios? And there was that reference, that letter that Rachel showed that came out in 2005, right? So we're talking in 2014 here. In 2005, post-Katrina, I don't know how many of you read that little yellow highlight in there, but the last sentence was, many evacuees' medical records and prescription histories are lost. And SureScripts actually stepped in then. Paul Yurig is maybe in the room still, but presented, there he is. And others stepped in, and they actually implemented some ad hoc quick response infrastructure to access med history. And that was valuable, and that's one of the lessons we took when we did our little tour through the Gulf Coast and throughout California and met with first responders and met with emergency management officials about what would be most relevant. And so that was an instructive experience for us. The next thing I would point out here is this July 2015 reference point, when CalEMSA, the EMS authority in California, came forward and worked with ONC and eventually won grant dollars to implement Pulse, to actually develop the first instance of Pulse. And this was unique. There were not a lot of organizations in the EMS space around the country that were thinking through the lens of health information exchange and interoperability. Still, there aren't. And these assets haven't really been deployed at a federal or state or local level. And so Dan Smiley in particular, who's the deputy director out there, deserves a lot of credit for putting his hand up and putting his organization forward to pursue this. And then they built it and they deployed it, and in 2017, it worked. Not perfectly. There's all sorts of room for improvement, which we're going to talk about, but it fundamentally did work. And we'll talk a little bit about how it worked back then. Rachel referenced when then Sequoia in 2018 became involved, and that was a really pivotal point, a transition point from kind of this localized concept of how you might deploy Pulse and being really state-specific to an opportunity to scale it truly at a national level. So Rachel hit this one, but the things I might highlight that make Pulse unique are one, that it leverages this existing, I don't know if you saw this in Rachel's slide, ESAR VIP, which I'm not even going to try to say what it means, but it's essentially a program from ASPR where first responders and clinicians get pre-registered so that during a disaster they can be healthcare volunteers. And what Pulse does is enable single sign-on from those tools, for example in California, so you don't have to get credentialed just in time to use a tool like this, but that your existing credentials, the existing site you might go to as a first responder, you can use as your credentials to then log into this tool and exchange information. So this has some circles and some lines, some words, but I'm not going to go through them. The key point here is that there's a bunch of steps today in Pulse, and one of the key things we're doing, which you're going to see in an upcoming slide, is to make less lines and less circles and make the thing easier to use. Because one of the fundamental questions that came up in the points that were made in our early travels around this was, if you're deploying tools just during disaster day scenarios, then they're not going to be used on a regular basis, and people have to be able to use them in really simplistic ways. So we're currently working with ONC, with Debbie and team at Sequoia on a range of areas to improve the next iteration of Pulse. So what's out there now is the version 1, the Pulse 2.0. One is to enhance the administrative functions, how the folks that are responsible for it at a state level in CalEMSA, for example, or in a Department of Health, if they've got responsibility, or a Medicaid agency, use the thing, both in terms of how broad is the query that gets launched, what are the audit features of it, what are the identity and access management controls that they can deploy when they activate Pulse. In the middle there, really importantly and deeply tied to the conversations going on this week at these meetings, are this extension beyond how we deploy this initially in California. In California, we leveraged all of the IHE standard transaction sets to be able to search for a patient and request document lists and go get structured clinical documents, but we did it outside of the construct of the eHealth exchange. And at the time, it made sense. California focused on leveraging really a version of the eHealth exchange that they call the California Trusted Exchange Network. And it worked, right? We've gotten 10, 11 nodes on. These are health information exchange organizations, health systems that directly participate. But it suffered from the problem of, well, what if Florida or Texas or North Carolina want to deploy this, and they don't have that C10? And so through partnership with eHealth Exchange, and Jay has been deeply involved, we've been able to focus, and I'll show you an image of this, on the basic ability to launch a query through the new gateway out to eHealth Exchange nodes, and eventually over the other networks that become care quality implementers. And then lastly, this important point of how you get to this thing, right? In California, they've got really robust use of their implementation of this ESAR VIP program, or the Disaster Healthcare Volunteer Program. People actually use the thing. They do pre-register. That's not true across the board, and every state has a slightly different deployment model. And so we're investing in how to make that pathway to get to Pulse more efficient, independent of which state Pulse gets deployed to. And this is that basic image, right? At the highest level, when you log into Pulse, you're logging into an existing asset in a state. You're not going to a new place. And that asset in California, for example, says Pulse is active because the administrators in California activated it. And then when they come into Pulse, there's a really basic experience, which we're trying to make even more basic, that has those 3 basic transaction sets behind it. Search for a patient, get a document list back, and then go get the documents that are most relevant. And instead of that being distributed to a set of nodes that are predefined, the 11 in California all get hit, it will go through the eHealth Exchange hub and then hit all of the participants in that network. And as, again, others become care quality implementers, a broader set of participants. And so as we think about participation in Pulse at a state level, the most efficient route to do that would to become an eHealth Exchange participant or a care quality implementer. Debbie made a really important point that this is not just a technology project. In fact, the minority of the work is a technology project. The more important part of this is how it actually gets deployed into a state, the governance within a state, the organization across agencies that have responsibility for disaster response, and all of the roles and responsibilities that have to be identified so that when it is used, there's a known operating process. And so part of the work that we're working on closely with Debbie and ONC is defining all of the documentation, certainly technically, that has to be available for Pulse, but also on all of the other operational aspects of getting it deployed and using it. And then that kind of extends into what states really need to do around Pulse. And again, each state's a little different, and disaster preparedness and response is a state and local concept. There are certainly major federal agencies that support it, but they support at the state and local level when there's a response. And so going through this process of planning to deploy Pulse and an implementation process where the thing actually gets deployed and they do tabletop drills and they have those roles and responsibilities defined, and then an ongoing readiness process so that they can actually activate the thing, as California has done on multiple occasions. So the last point I make before we maybe shift to questions is this is an incredibly cool use of the work that's been going on among so many people in this room, Sequoia, eHealth Exchange, Care Quality, Commonwealth, to leverage existing assets and not go create new connectivity. And the work that happens, Marianne mentioned data quality earlier in the Joint Document Content Work Group. Did I say those words in the right order? Is it Joint Document Content Work Group? Anyone?
Yeah, that's good.
Anyone know that work? The output from that work that hopefully will be adopted and implemented that improves the quality of CCDs, fundamentally then improves the quality of this tool. And as we think about how to surface really relevant information and not just a chronological list of the most recent continuity of care documents over eHealth Exchange, but parsing and pulling out medications, going back to the SureScripts example, or in scenarios where there's dialysis patients, which I'll hit on in a second, that don't have the dialysis prescription or really important lab results available. Being able to pull that up and surface it for specific scenarios is important. So Pulse is an early entry to the importance of how the work that this community does on interoperability can support disaster preparedness and response. And the fact that going all the way back to that 2005 example, there's been very little progress, and the teams at ASPR and ONC would be the first to put their hands up and say, that's true, that they have not leveraged these assets to support parts of their mission. And so Pulse is a first step. There are other tool sets in our world that are highly relevant to their core mission, like the ability to identify missing persons during mass population displacements, whether it's a hurricane or a fire or an earthquake, the ability to see that someone has arrived at a hospital and take a list. And that's been deployed in Florida previously, where they've been able to identify thousands of missing people that the Red Cross had on a missing persons list. And then lastly, ASPR and a woman there named Kristen Finney has done really cool work leveraging large data sets from Medicare to identify electricity-dependent beneficiaries in advance of a disaster so that they can stage equipment and engage them. They're trying to do things so they can actually text them in advance to let them know, so that if you are a dialysis patient and you are in one of these school gymnasium settings where HHS is now able to deploy assets around portable dialysis, that there's also the data set available over the eHealth Exchange on dialysis prescriptions, where 90% of the dialysis centers in the US participate in eHealth Exchange, and that key information embedded in the CCDs can be made available. So Pulse is an early but important start, but it starts to paint a picture of a much broader opportunity to apply, again, the work that this group and the broader community does in interoperability. So with that, Debbie, maybe I'll hand it back.
Yeah.
And
Yeah.
questions.
Okay, so just to sort of circle back in terms of the states that are participating or have started to participate in Pulse and are currently on the advisory council, I did want to circle back just a little bit and give a couple of updates for the states who were not able to be here today to discuss the current status of Pulse implementation in their states. As Rachel and Scott mentioned, California is a use case that has been put into practicality and into practice. So they are in the process of connecting HIOs and so forth to the Pulse application and program, and continue to work on moving toward Pulse 2.0. I did want to mention Florida as well. Certainly Florida is very interested in implementing Pulse and has been highly participative on the advisory council. Their current status is that they were approved for 90-10 funding, and I'm going to ask Rachel in a couple of minutes as we start into our sort of question and answer chat discussion to talk a little bit about funding resources for states and how this might play out. I will say that as a former state employee for Virginia, I am working on educational materials. I am highly familiar with the process for going through requests for federal funding, so I'll be working on some educational materials for you all. If your states or localities or jurisdictions are interested in joining, that might be helpful in determining what types of resources to go after and then what that actually involves. Different states are different in the way they do this, so we want to be helpful. They will be fairly generic, but I think we can provide some guidance there. So in Florida, they do have their 90-10 high-tech funding from CMS. They have rebranded, as I mentioned, their Pulse program to, instead of Pulse, to call the Emergency Patient Lookup Service. And they are in the process of determining the best path forward for procurement. In Texas, I want to mention that they have also secured their funding and have been working with key stakeholders to start planning and implementing prior to the 2020 hurricane season for Texas. They're also working on, and I think Scott mentioned this, is a really key component for implementing Pulse or actually any program, and we talked about this a little bit in one of the sessions before, is around governance and how this program will be governed, managed, organized within a particular state. So Texas is in this process of doing that as well. Virginia obviously is also very interested in Pulse and is in the process of sort of kind of figuring out where this might stand. In Virginia, there is a Connect Virginia HIE vendor, and most likely Pulse would be a product or an add-on service, value-added service for that HIE service. So I do want to ask a question or two just to kind of follow up with a couple of things that we were chatting about during our presentations. So Scott, if you want to talk a little bit more about Pulse 2.0 and some of the features that might be coming in that, and some of the items that make Pulse easier to use.
Yeah, sure. So maybe I'll hit three. One is that in the first iteration of Pulse, there's a heavy reliance, frankly, on our team at AI that we want to get away from an administration standpoint, where we want administrators within the state to be able to choose which geographies can be queried or which geographies are active for users to come into. So both kind of the user side and then where queries get launched to. Two is a really basic idea of reducing the number of steps to get from screen one to relevant patient information. And so we've been working with our colleagues in California that have actually used the tool to get feedback from a user experience perspective and limit the process to the bare minimum. And then lastly, one of the challenges in clinical data exchange generally that I think we all know is that you get this list of mostly documents, and there's important progress there in terms of getting to more granular data types, but a lot of the time you're kind of sifting through these lists of pretty big document sets. And so working with those that work in this field and identifying what are the most relevant pieces of data. And in many cases, it's the stuff that's relevant in any clinical scenario, right? You want meds, you want problems, you want conditions, but in some cases, there are more nuanced data sets that pair with something like that Empower initiative to pull back and parse out the dialysis prescription, for example, and to highlight that, hey, this exists, here's the easy way to get to it without having to go to CCD number 4 on the list, and then wade through to page 14 to get to it.
Great. And Rachel, could you talk quickly about the funding opportunities, resources from the ONC federal level? And
Absolutely. So we've been working very closely with CMS over the past few years. Some of you all may know Tom Novak very closely. But he has been able to secure that Pulse is a funding opportunity through using some of the high-tech funding that is coming through the state Medicaid offices. So that's really great in the sense that they have support for any Pulse initiatives within the state to use that funding. There's also some limited funding, some flexible funding, I should say. So every state gets public health emergency preparedness funding in some capacity. So some of those funds may be also used for Pulse also. However, it's a little bit harder to break into that funding because in most cases, states have already allocated that funding for specific purposes. But there is the possibility of using that as well. And then ONC as well as ASPR and some of our other federal partners continue to seek out additional federal resources and trying to fund pieces of Pulse as well.
great. Before I ask one more question, or if anybody has any questions, please come to the microphone so we can make sure we get your questions in as well. Yes.
Leslie Kelly Hall. I'm a former Chief Information Officer, and I'm a patient advocate, founder of Engaging Patient Strategies. But I'm also on the Direct Trust Board and on the Care Quality Steering Committee. But more importantly for you, I lost my home to the ocean and was a victim of disaster. And healthcare is part of it. And the acute things that you mentioned are absolutely critical. But it's day two that's tough.
Yes.
So I encourage you to work with 211, and if you are started already, what linkages are there between 211 across the country and the local healthcare facilities, and through Pulse, what kind of anchoring can you give to combining all of these resources so that even when you're cared for appropriately, day two isn't so horrible. Thank you.
Thank you.
Thanks so much. I'm so sorry about your loss. I can only imagine that's super difficult. And, I think 211 definitely, we've thought about that and bringing those pieces in, and I do see a complete value of that. I think that there is some conversations going on specifically in California on how to make the triage process a little bit more comprehensive so that it does include also connecting people with other resources within the community as they move forward. And it's not just your physical health, but it's your mental health and your overall well-being that needs to be happen. Absolutely. Thank you.
Yes.
I am Marilee with Zen Healthcare IT. This question's for Scott. My question is, when we're doing federated queries, obviously the simple problem around getting a patient demographic match, so we actually find the patient, tends to be a big problem. How are you guys addressing that?
Yeah, I mean, we're wrapped up in the challenge like everyone else, this initiative is, which, same thing on the data quality side. There's just a lot of room for improvement. And the model here is a distributed patient demographic query that hits each node, and each node has to figure it out and then let the service know whether or not they have a match. And so we're not deploying any kind of centralized patient identity management solution through this technology. We're relying on kind of the fundamental concepts of the eHealth Exchange and other national networks to distribute queries and then respond. So we're in it with everyone else.
All right. Any other questions? So I want to thank Rachel and Scott for joining us today, and thank you all for your attention.